Just take a second and try to imagine something for me. Picture this tiny sort of butterfly-shaped organ sitting right there in your neck.
Right in front of the windpipe.
Exactly, yeah. Right in
Ah.
front of the windpipe. And it weighs almost nothing. Maybe an ounce.
Yeah.
It is entirely unassuming. I mean, most days, you don't even know it's there.
You really don't.
But this microscopic little butterfly, it actually dictates almost everything about how you feel today.
Oh, absolutely.
I'm talking about, how fast your heart is beating right this very second, whether you feel comfortably warm or if you're shivering cold, how sharply your brain is processing my words right now, even how quickly your stomach is digesting the breakfast you had this morning.
It basically functions as the body's ultimate master thermostat. And we aren't just talking about body temperature here, though, it does control that too. We are looking at the metabolic thermostat for virtually every single cell in your body. I mean, from the neurons in your brain all the way down to the muscle fibers in your toes, they all rely on the chemical signals that originate from this one small location.
Which is exactly why you are here listening to this. Welcome to your custom deep dive. Today, our mission is to just completely decode this entire system.
And it is a complex system.
It really is. So we are looking through the incredibly detailed medical and nursing study guides you provided to us.
Yeah.
And we are not just going to sit here and read off a laundry list of what happens when this system breaks down.
No, that's what textbooks are for.
Right, exactly. Our goal today is to understand the profound why behind the symptoms, the treatments, and honestly, the terrifying medical emergencies that happen when this butterfly flutters just a little too fast or stops flapping its wings altogether.
Yeah.
We are talking about the thyroid, and of course, its tiny hidden neighbors, the parathyroid glands.
The overarching thread that you will notice today is really the sheer delicacy of the human endocrine system. It's so fragile.
It is. It operates on these intricately balanced, interconnected feedback loops. If you disrupt just one variable, say, a lack of a single nutrient in your diet, or even an accidental or physical squeeze of the neck during a medical exam.
Which is wild, by the way. We'll get to that.
We will. But it creates this massive systemic ripple effect. The human machine relies on these microscopic chemical drops to maintain equilibrium. And when that equilibrium shifts, the results can be catastrophic.
It is just endlessly fascinating to me that such small glands possess this almost totalitarian power over the entire body. We're talking about an organ that you can't even really feel unless something is terribly wrong with it.
Exactly.
So let's unpack this from the ground up. Let's start in the engine room, so to speak. What is the thyroid? Where is it geographically? And how does it actually work when everything is running smoothly?
Geographically speaking, it sits in the anterior neck, so draped right in front of the trachea or your windpipe.
It has these two lobes connected by a little bridge of tissue called the isthmus, hence the butterfly shape. But to understand how it actually works, you have to look at its chain of command.
Right, because it doesn't just act on its own.
No, not at all. The thyroid does not possess a mind of its own. It is very much a subordinate gland. It takes its direct orders from the anterior pituitary gland, which is located way up in the brain.
And the pituitary takes orders from even higher up.
Exactly. The anterior pituitary, in turn, takes its orders from a higher structure in the brain called the hypothalamus.
Okay, I love a good analogy. So let's look at this like a corporate hierarchy.
Let's do it.
So the hypothalamus, sitting way up there in the executive penthouse of the brain, is the CEO.
Right.
It's constantly monitoring the market, meaning, it's checking the blood for temperature, energy levels, just the overall metabolic state of the body.
Constantly surveying.
Yeah. So if a CEO decides, hey, production's down, we need way more energy, they don't just go down to the factory floor themselves.
No, they call the middle manager.
Exactly. The pituitary gland is that middle manager. So the middle manager types up a memo, which in this biological case is a hormone called TSH, or thyroid stimulating hormone.
Right.
And they send that memo down to the factory floor. And the thyroid gland down in the neck, that is the factory floor. They receive the TSH memo, and they finally get to work.
That analogy holds up beautifully, but let's push it a little further into the actual biology of it.
Sure.
When that TSH memo arrives at the thyroid gland, it physically binds to specific receptors on the surface of the thyroid cells.
Like putting a key in a lock.
Yes. And this is the direct signal to start manufacturing. But obviously, a factory cannot produce a product without raw material.
Right. It needs supplies.
Exactly. For the thyroid to manufacture its hormones, it relies entirely on two crucial ingredients that are derived from your diet.
And those are?
Protein, specifically an amino acid called tyrosine and iodine.
Iodine.
Without adequate protein and iodine intake, it doesn't matter what the memo says. The factory receives the orders from management, but it simply cannot assemble the product.
Which brings us to the product itself, the chemical messengers. The notes you provided break down three main hormones that this factory produces, stores, and releases.
Yeah, let's start with the big ones.
Right, T4 and T3.
So T4 stands for thyroxine, and T3 is triiodothyronine.
Those are mouthfuls.
They are. But the numbers 4 and 3 actually just represent the number of iodine atoms attached to the molecular structure.
Oh, that makes it so much easier to remember.
Right. Now, T4 is the bulk product. It accounts for about 90% of the hormones produced in the thyroid gland.
Okay.
It is very abundant in the bloodstream. But T3, even though it's produced in much, much smaller volumes by the thyroid, is the actual biological superstar.
How so?
T3 is significantly more potent. It's roughly 4 times more metabolically active than T4.
So it's kind of like T4 is the crude oil being pumped out in massive barrels,
Right.
and T3 is the highly refined rocket fuel.
That is a very apt comparison. In fact, most of the T3 in your body isn't even actually made in the thyroid.
Wait, really? Where is it made?
Your peripheral tissues, like the liver and the kidneys, they actually take that abundant T4 crude oil that's floating around, and they physically strip away one iodine atom to convert it into the highly active T3 rocket fuel right when and where they need it.
Wow. That's incredibly efficient.
It is.
And together, T3 and T4 affect literally all other body systems. I mean, they don't just float around in the blood looking pretty. They dictate the metabolic rate of all our cells.
Every single one.
They increase the heart rate, they increase the respiratory rate, they stimulate bone formation, and the notes explicitly mention that they act as an insulin antagonist. Why is that piece so important?
Well, consider the basic mechanism of metabolism. Metabolism requires fuel, and the primary fuel for our cells is glucose, or sugar.
Right.
Insulin's job is to pull glucose out of the bloodstream and store it away in the tissues for later.
Right, to lower blood sugar.
Exactly. But if the thyroid hormones are ramping up your metabolism, really turning up the internal furnace, those cells need immediate access to fuel.
They can't wait around for storage.
Exactly. By acting as an insulin antagonist, thyroid hormones essentially push back against insulin. They keep glucose freely available in the bloodstream, so the cells have this constant supply of energy to burn.
So it's essentially ensuring the supply chain of fuel isn't locked away in a warehouse somewhere while the factory is trying to run at max capacity.
That's the perfect way to put it.
Now, there's a third hormone produced here, which feels a little like the odd one out, but the notes really highlight it. Thyrocalcitonin, or just calcitonin.
Yeah, calcitonin is interesting because it operates completely outside of that CEO to factory chain of command.
Oh, really?
Yeah, it doesn't care about TSH at all. It responds purely to the levels of calcium in your blood.
Okay.
If your blood calcium levels get too high, the thyroid releases calcitonin. Its entire physiological purpose is to lower that calcium.
And how does it do that?
It targets the bones, basically instructing them to stop breaking down and to keep calcium locked in the skeletal vault. It also signals the kidneys to excrete more calcium into the urine and tells the intestines to absorb less calcium from your food.
So we have the CEO in the brain, the middle manager, sending the TSH, the factory floor, using iodine to pump out T3 and T4, and then this separate security guard, calcitonin, just managing the calcium vault.
That's the system.
It's a highly efficient, delicately balanced machine. But here's where it gets really interesting, and honestly, it's scary.
Yeah.
If you're listening to this and you've ever felt chronically exhausted for no clear reason, this next part is vital. What happens when the factory workers go on strike? What happens when this massive systemic engine just slows down?
This introduces our first major pathological state, hypothyroidism.
Hypo meaning under.
Exactly. The prefix hypo means under or below. We're looking at a state where the thyroid gland secretes a reduced amount of hormone, or, in severe cases, it ceases secretion entirely. And because these hormones govern the metabolic speed of every single cell, their absence forces the entire body into a drastically decreased metabolic state. Everything simply powers down.
The sources really emphasize that this is usually a very gradual decline.
Right.
It's not like you wake up on a Tuesday and the factory is totally shut down. It sneaks up on you.
It does. It can take years.
And this is exactly why it so often goes undiagnosed, especially in the elderly population. The fatigue, the sluggishness, it just gets written off as, getting older.
Absolutely. It's a very insidious disease.
But medically, the sources categorize this failure into 3 distinct types based on that corporate hierarchy we built earlier. Let's break those down.
Let's trace the points of failure. The most prevalent form is primary hypothyroidism.
Yeah.
This means the breakdown is localized to the factory floor itself. The thyroid gland is damaged or destroyed.
So the CEO is screaming for more energy, the middle manager is sending thousands of TSH memos, but the factory itself is just a burned-out husk.
Precisely. And the most common cause of this primary failure is an autoimmune condition called Hashimoto's thyroiditis.
Hashimoto's. Okay, what's happening there?
In Hashimoto's, the patient's own immune system misidentifies the thyroid gland as a foreign invader.
Like it's a virus or something.
Exactly. So white blood cells infiltrate the gland and they systematically destroy the hormone-producing cells.
That's terrible.
It is. Other causes of primary failure include the physical removal of the gland during surgery, radiation therapy for neck cancers, or even certain medications that are just toxic to thyroid cells.
Right. Then you have secondary hypothyroidism. This is where the factory is perfectly fine, the machinery is oiled and ready to go, but the middle manager is failing.
Right, the anterior pituitary gland is damaged.
Maybe by a tumor or something, and it simply fails to produce enough TSH to stimulate the thyroid.
And if the pituitary isn't sending the memo, the thyroid just assumes no hormones are needed, so it sits idle.
That makes sense. And finally, tertiary hypothyroidism, which the notes say is the rarest.
Very rare.
This is a failure at the very top. The hypothalamus, the CEO, fails to send the initial signal to the pituitary, usually due to, like, severe brain trauma, a tumor, or a stroke.
Yes. Now, beyond these adult-onset variations, the notes also highlight a specific, really tragic pediatric condition called cretinism.
Oh yeah, this part was heavy.
It is. This is congenital hypothyroidism, meaning it develops in utero or immediately at birth.
This really stood out to me. The infant lacks T4 entirely at birth. And remember, we just established that T3 and T4 don't just run the daily metabolism. They're absolutely essential for cellular growth and development.
The physiological stakes in infancy are incredibly high. The developing brain relies heavily on thyroid hormones for myelination.
Myelination, that's the protective coating on the nerves, right?
Yes, exactly. It's the process where nerve fibers are coated in a protective sheath that actually allows electrical signals to travel. Without T4, that neural development just halts.
God.
These infants face profound mental defects, a severe failure to thrive physically, drastically reduced organ function, and skeletal deformities.
Now, reading through the source notes, there was this handwritten question in the margins that I thought was just so poignant. The original reader asked, is there not a way to test or introduce a T4 supplement early enough to the infant to combat these effects?
It's an incredibly astute question, and addressing it reveals one of the greatest systemic triumphs of modern public health, honestly.
Because it is preventable, right?
Yes, because the neurological damage from cretinism is completely irreversible once it occurs. Early diagnostic screening is literally the only defense.
What do they do?
In modern obstetrics, we perform a mandatory heel prick blood test on newborns within the first few days of life. This specifically checks their thyroid levels, among other things.
Okay.
If we detect an absence of T4, we can introduce synthetic hormone supplements immediately. If treated early enough, we completely prevent those severe developmental defects, and the child can live a totally normal life.
It really underscores how critical these chemicals are. I mean, just a few microscopic drops dictate whether a human brain develops normally or not.
It's truly profound.
So let's look at the symptoms in an adult experiencing this slowdown. The notes give a great, simple cheat code here. Hypo equals slow.
I always tell students to remember that. Hypo equals slow.
Everything in the body is going to decelerate.
Mm-hmm.
But when you look at the systemic list of manifestations, I mean, it is brutal.
It is systemic, sparing literally no organ. Let's look at the cardiopulmonary system first.
Okay.
The heart rate drops, a condition called bradycardia. But it's not just beating slower. The actual contractility of the heart muscle, the physical force of the squeeze, is weakened.
So it's weak and slow.
Exactly. This leads to a massive drop in cardiac output. Breathing also slows down, which is termed hypoventilation. The patient takes fewer breaths, which means less oxygen is entering the blood, leading to this chronic shortness of breath.
The notes also mention pleural effusions here, which is fluid building up around the lungs. Why does a lack of metabolism cause fluid to build up in the chest cavity?
This comes down to capillary permeability.
Capillary permeability, okay.
Without adequate thyroid hormone, the cells lining the blood vessels actually become slightly leaky. Proteins escape the blood vessels into the surrounding spaces, and water naturally follows those proteins due to osmosis.
Oh, wow.
Yeah. This causes fluid to pool in the pleural space around the lungs, making it physically harder for the lungs to expand.
And the patient feels this metabolic crash profoundly, right? They have an extreme constant intolerance to cold.
Yes.
Like you could be in a room set to 75 degrees and they are shivering in a thick sweater. Their internal furnace is basically just shut off, causing their core basal body temperature to drop. And then there are the neurological symptoms.
The brain is starved for energy, so we see slowed intellectual function, slurred speech, confusion, and impaired memory.
It must be terrifying for the patient.
It is. And the psychosocial impact is devastating. Patients experience paranoia, excessive sleeping, sometimes 14 to 16 hours a day, and this overwhelming, crushing fatigue.
The notes say they are often misdiagnosed with depression.
Very frequently. They are misdiagnosed with clinical depression because their brain literally lacks the metabolic ATP energy to produce neurotransmitters and function normally. They appear deeply depressed, but it's purely metabolic.
We also see very specific, noticeable physical changes. Their skin becomes cool to the touch, dry, and scaly. Because, cellular regeneration is slowed down. Wounds take forever to heal.
Right.
Hair thins out, becomes incredibly coarse, and they can experience massive hair loss. But one of the most classic signs is a specific type of swelling.
Yes, myxedema.
Right? The notes mention periorbital edema, which is severe puffiness around the face and eyes, a thickened tongue that causes a hoarse, raspy voice, and non-pitting edema to the hands and feet. Let's decode that term. What makes swelling non-pitting?
So standard edema, like when your ankles swell after a really long flight, is mostly just water pooling in the tissues. If you press your thumb into it, it leaves a little pit or an indentation for a few moments.
Right, pitting edema.
Exactly, but in severe hypothyroidism, the swelling isn't just water. The lack of thyroid hormone causes a buildup of complex sugars and proteins called mucopolysaccharides in the connective tissues.
Mucopolysaccharide.
Yes. This substance is thick, almost gel-like. It draws water into the tissues, but because of the gel-like matrix, if you press your thumb on it, it doesn't leave an indentation. It just feels thick, waxy, and rigid.
Wow.
This specific type of swelling is called myxedema.
Okay, let's unpack another symptom that just sounds like a total biological contradiction to anyone without medical training.
I know exactly what you're going to say.
The notes state that a hyperthyroid patient will experience significant weight gain, despite experiencing anorexia. Now, obviously, in this medical context, anorexia just means a complete loss of appetite, not the psychiatric eating disorder.
Correct.
But how is it physically possible to gain weight if you have zero desire to eat and are barely taking in any calories?
If you look at the fundamental equation of thermodynamics, it makes perfect, if incredibly frustrating, sense. Your body weight is determined by the ratio of energy consumed versus energy expended. In a severe hypothyroid state, the basal metabolic rate, the absolute baseline energy your body burns just to keep the lights on, keep the heart beating, and maintain temperature, has plummeted to near zero.
So they aren't burning anything.
Nothing. So even if the patient is eating only a tiny fraction of their normal diet because they have absolutely no appetite, their body isn't burning any of it. The body takes those few calories, assumes it is starving, and immediately stores them as fat.
That is wild.
The engine is so cold that any fuel introduced just piles up unburned.
Wow. I mean, if you're a patient experiencing that, it must feel like your body is completely betraying you.
It absolutely does.
And it messes with the reproductive system, too.
Yeah.
Women experience severe menstrual disturbances or they just stop ovulating entirely. And men experience decreased libido and impotence. So to diagnose this, doctors look at the patient's history, the physical symptoms we just discussed, and they draw blood. They're primarily looking for decreased T3 and T4 levels, but they also look closely at the TSH levels to figure out where the breakdown in our corporate hierarchy actually is.
Right. Let's test the logic of the feedback loop here.
Okay, quiz me.
If a patient has primary hypothyroidism, meaning the factory in the neck is broken, what do you anticipate their TSH levels will look like?
Well, if the factory isn't producing T3 and T4, the CEO and the middle manager are going to panic. They're going to send out 1 million memos demanding production. So the TSH levels in the blood would be screaming high.
Correct. Elevated TSH with low T3 and T4 is the classic textbook lab presentation of primary hyperthyroidism. The pituitary is desperately trying to whip the failing thyroid into shape.
But if the problem is secondary?
Right, meaning the pituitary middle manager is the one broken, then both the T3, T4, and the TSH will be low. The memos are just never sent.
The notes also mention using a thyroid scan with radioactive iodine uptake. If the gland is failing, the scan will show a very low uptake of the iodine, proving the factory isn't pulling in raw materials.
Exactly.
They will also run an EKG to check for that dangerous sinus bradycardia, and crucially, they check lipid levels. Why are cholesterol and triglycerides elevated in these patients?
Thyroid hormone plays a major role in the liver's ability to process and clear cholesterol from the blood.
Oh, I didn't know that.
Yeah. When thyroid hormone drops, the liver's processing machinery just slows down, causing LDL, the bad cholesterol, to accumulate in the bloodstream. This significantly accelerates the risk of atherosclerosis and heart disease.
So we have a diagnosis. The factory is closed for business. Since the body can't produce the hormone, medical science has to step in to artificially replace it. Enter the medication. We are moving into part 3, the lifelong fix.
The gold standard for treatment is levothyroxine sodium, widely known by its brand name, Synthroid.
Synthroid.
Yeah.
Everyone knows someone on Synthroid.
It's incredibly common. This is a synthetic pharmacologically manufactured form of T4, and it is absolutely crucial for patients to understand. This is a lifelong therapy. We aren't jump-starting the thyroid to heal it. We are permanently outsourcing its job to a pill.
And this pill has an incredible responsibility. It has to increase the metabolic rate, stimulate protein synthesis, increase cardiac output, improve renal perfusion so the kidneys actually work, increase oxygen use, raise body temperature, and restore blood volume.
It literally breathes life back into the slowed-down human machine.
But administering it, it's not like just popping a daily multivitamin.
Oh, far from it. The protocol for prescribing and administering levothyroxine is incredibly rigid. First, the dosing strategy is heavily focused on going low and slow.
Low and slow.
Yes. You administer it orally every day, but you begin with a very small, almost microscopic dose and gradually increase it every 2 to 3 weeks, carefully monitoring the metabolic response.
Why the slow rollout? Like, why not just give them the normal amount of hormone they need right away and get them feeling better?
Because you risk shocking the system, particularly the cardiovascular system.
Oh, because of the heart rate.
Exactly. Imagine an engine that has been running at 10 miles an hour for 5 years. The parts are stiff, the cardiovascular pipes are maybe a bit clogged with that high cholesterol we mentioned. If you suddenly dump pure rocket fuel into that engine, it will try to instantly run at 100 miles an hour.
You are going to blow a gasket.
You're going to blow a gasket.
Right. The notes specifically say to be extremely cautious with any patient who has known cardiovascular disease because this medication drastically increases the oxygen demand on the heart.
Very drastically.
If the heart arteries are narrowed and the heart suddenly needs twice as much oxygen to beat faster, you can trigger angina or a full-blown heart attack.
Yes.
In fact, it's explicitly contraindicated for anyone who has recently suffered a myocardial infarction. The stimulant effect is just too dangerous for healing cardiac tissue.
There are also strict rules for the patient taking it at home. It must be taken daily, and you absolutely cannot stop it abruptly. Furthermore, the notes issue a very strong warning. Do not change the brand of medication.
I found this interesting. Usually generic drugs are totally fine. Why the strict adherence to one brand here?
It all comes down to bioavailability.
Bioavailability, meaning how the body absorbs it.
Right. The active ingredient, levothyroxine, is the exact same. But the binders, fillers, and dyes used by different manufacturers can slightly alter how quickly and completely the drug is absorbed in the gut.
Does a slight alteration really matter that much?
It does, because the therapeutic window for thyroid hormone is so incredibly narrow. Even a 5% difference in absorption between brand A and brand B can throw off the patient's delicate chemical balance. It can plunge them back into hypothyroidism or push them into a hyperactive state.
Wow. I conceptualize Synthroid as a very, very picky VIP guest at an exclusive restaurant.
I like this. Let's hear it.
You cannot just seat this VIP with anyone. The notes emphasize it must be taken daily on a completely empty stomach, typically 30 to 60 minutes before breakfast.
Right.
And you have to keep it strictly separated from other common supplements. If you take fiber supplements, calcium, iron, or antacids, they will actually bind to the Synthroid in the gut and block its absorption entirely.
They absolutely
You have to space those doses at least 4 hours apart. The VIP demands a private table, or they refuse to do the work.
That analogy is highly practical for anyone taking this medication. If you seat the VIP next to calcium, the VIP leaves the restaurant completely unabsorbed.
Exactly.
And as the metabolism slowly speeds back up, the healthcare team has to monitor everything. Diabetic patients, for instance, might need their insulin adjusted because their body is suddenly metabolizing sugar faster.
The whole system is waking up.
Yes. The nurse must constantly monitor for signs of overmedication, which is a state called thyrotoxicosis.
Which is basically accidentally pushing the patient into hyperthyroidism. Symptoms of that would be sudden anxiety, tachycardia, tremors, chest pain, fever, and rapid weight loss.
It is a constant tightrope walk.
But what happens if the patient falls off the tightrope? Like what happens if they stop taking their meds, or they're an elderly patient who remains undiagnosed, and they suddenly get hit with a severe physiological stressor, like a massive bacterial infection, major surgery, or chemotherapy?
The system doesn't just slow down, it crashes. It precipitates the ultimate hypothyroid medical emergency, myxedema coma.
The name alone sounds terrifying, myxedema coma.
It is a profound, life-threatening crisis requiring immediate ICU admission and extremely aggressive intervention.
Okay, let's break it down.
Myxedema coma represents a catastrophic reduction in cardiac, respiratory, and neurological function. The cardiac output drops so profoundly low that the blood pressure plummets, gas exchange in the lungs fails, and organ perfusion stops.
The organs stop getting blood.
Exactly. The tissues literally begin to starve for oxygen, leading to rapid multi-organ failure and a remarkably high mortality rate, even with the best modern medical care.
Let's trace the physiological cascade of failures here, because it is a brutal, unstoppable domino effect if you don't intervene.
It is.
The notes list the clinical manifestations. It usually starts with a sudden reduction in consciousness and cognition. The patient becomes incredibly lethargic and slips toward a comatose state. Then, hypoventilation kicks in. The breathing becomes so slow and shallow that it leads to acute respiratory failure.
The mechanics of that respiratory failure are twofold. First, the muscles of the diaphragm are simply too weak to pull air in. Second, the brain's respiratory center becomes completely insensitive to carbon dioxide.
Wait, so the brain just forgets to tell the lungs to breathe?
Essentially, yes. Normally, when CO2 builds up in your blood, your brain forces you to take a breath. In myxedema coma, that alarm system fails. The CO2 builds up to toxic levels, causing respiratory acidosis.
So they stop breathing entirely.
These patients almost always require immediate mechanical ventilation intubation just to manage their airway and force gas exchange.
Meanwhile, the cardiovascular system is collapsing. The patient develops severe hypotension, which is dangerously low blood pressure, and profound bradycardia. The pulses become so weak you could barely palpate them in the wrists or ankles. And their internal thermostat completely breaks.
Yes.
Their body temperature plummets, resulting in significant life-threatening hypothermia.
Furthermore, the massive metabolic shutdown causes severe electrolyte and metabolic crashes. Let's look at the why behind these.
Please do.
They develop hyponatremia, which is dangerously low blood sodium. Why? Because the weakened heart isn't pumping enough blood to the kidneys. The kidneys panic, thinking the body is actively bleeding out, so they release antidiuretic hormone, or ADH, to aggressively hold on to water.
And all that water just dilutes whatever sodium is.
Exactly. All this retained water dilutes the sodium in the blood.
And they also develop hypoglycemia, dangerously low blood sugar.
Correct. The liver's ability to generate new glucose, a process called gluconeogenesis, completely halts without thyroid hormone.
This is a total system failure.
It is. This combination of low sodium and low sugar can lead to cerebral edema, which is swelling of the brain tissue, increased intracranial pressure, massive seizures, and ultimately an irreversible coma.
So if a patient rolls into the ER in this state, how do the doctors and nurses fight back?
Aggressively.
The notes are very clear. Prevention is the first step, obviously. Identifying changes in a hypothyroid patient early. But once they cross into myxedema coma, the treatment is based purely on clinical presentation. You do not wait around for the lab results to confirm the low T4.
You can't wait. Time is literally brain tissue in this scenario. The management priorities follow the classic ABCs of resuscitation. Number 1, airway. As we mentioned, intubation and ventilator support are often immediately necessary. Number 2, fluid replacement. You administer intravenous normal saline to restore blood volume and blood pressure, but you must monitor those sodium levels incredibly closely to ensure you aren't exacerbating the dilution.
And they desperately need the thyroid hormone, right? But you can't just give them their daily Synthroid pill.
You cannot. The gastrointestinal tract is practically paralyzed by the coma. This is a condition called a paralytic ileus.
So the pill would just sit there.
It would just sit in the stomach, completely unabsorbed. You have to administer massive doses of intravenous levothyroxine to get it straight into the central circulation. You also administer Thyroid hypertonic glucose to immediately correct the low blood sugar.
The notes also mention administering corticosteroids. Why give steroids to a thyroid patient? That seems random.
It is a critical protective measure.
No, so.
The entire endocrine system is under catastrophic stress. In these extreme states, the adrenal glands, which normally produce cortisol to handle physiological stress, are often simultaneously compromised. If you rapidly ramp up the body's metabolism with IV thyroid hormone, but the adrenal glands can't produce enough cortisol to support that sudden metabolic demand, you can push the patient into an acute adrenal crisis, which is fatal.
Oh, wow.
Yeah. The IV corticosteroids proactively support the body's stress response while the thyroid hormone kicks in.
You also have to manage their body temperature.
Okay.
But the notes specify, gently support the temperature, do not rapidly rewarm them.
This is crucial.
Because if you throw a bunch of heated blankets on them, their peripheral blood vessels will dilate to absorb the heat, which steals all the blood away from their already failing heart and brain, plunging them into cardiovascular shock.
Exactly.
You just keep the room warm, maybe use regular blankets, and keep them in a semi-high Fowler's position, sitting up a bit, to help their lungs expand.
It is an incredibly delicate, terrifying resuscitation.
Okay, let's take a collective breath.
Good idea.
That is what happens when the factory completely shuts down and the engine stalls into a coma. But nature loves a pendulum. Let's swing entirely in the opposite physiological direction.
Let's do it.
What happens when the gas pedal gets stuck to the floor? Let's talk about hyperthyroidism.
We are transitioning from a hypometabolic state to a hypermetabolic state. Hyperthyroidism is characterized by a sustained, excessive secretion of thyroid hormones into the bloodstream.
Sustained and excessive.
Yes. This leads to a massive exaggeration of all body functions and an extreme, relentless increase in sympathetic nervous system activity.
The sympathetic nervous system is your fight-or-flight response. So in this disease, the fight-or-flight switch is basically duct-taped in the on position.
That is a highly accurate description.
It's the second most common endocrine disorder, notably most prevalent in women aged 20 to 40. Now, just like there were multiple causes for the slowdown, there are multiple triggers for the overdrive. Things like thyroiditis, which is inflammation of the gland releasing stored hormones, or a toxic adenoma, which is a hormone-producing tumor, or a toxic nodular goiter.
Yes.
But the big one, the one that causes the vast majority of cases, is Graves' disease.
Graves' disease is incredibly fascinating from an immunological standpoint.
Why is that?
Because it is an autoimmune disorder, much like Hashimoto's, but the mechanism is entirely reversed. Instead of the immune system destroying the gland, Graves' disease actually overstimulates it.
How does it do that?
The patient's immune system erroneously produces specific antibodies known as thyroid-stimulating immunoglobulins, or TSIs.
And what's wild is that these TSI antibodies basically act as chemical counterfeiters.
That is exactly the mechanism. These antibodies possess a molecular structure that allows them to attach directly to the TSH receptors on the surface of the thyroid gland.
They mimic the memo.
They perfectly mimic the legitimate TSH memo sent from the pituitary gland. So the thyroid gland receives millions of these fake, counterfeit memos screaming, "Produce more! Produce more!"
And the thyroid can't tell the difference.
It cannot. The thyroid, unable to tell the difference, complies. It increases hormone production massively. Furthermore, to handle this constant, overwhelming demand, the gland physically hypertrophies, it grows larger, and increases the actual number of glandular cells.
And that physical enlargement of the gland is what we call a goiter. You can physically see it as a large, pronounced swelling in the front of the neck.
You can.
Now, Graves' disease has some extremely specific and, frankly, very distressing physical manifestations alongside the goiter. The notes highlight something called exophthalmos.
Exophthalmos is perhaps the most classic, recognizable visual hallmark of Graves' disease. It presents a severe bulging of the eyes.
Bulging eyes, okay.
But it's crucial to understand this isn't just a muscle spasm pulling the eyelids back. It is a profound anatomical change occurring within the eye socket.
What exactly is happening behind the eye?
Those same TSI antibodies that are attacking the thyroid. They also happen to recognize and bind to fibroblasts, which are connective tissue cells located directly behind the eyes.
Oh, wow.
Yeah. When these antibodies attack the retroorbital tissue, it triggers massive inflammation. The fibroblasts start secreting complex carbohydrates that draw in massive amounts of water, leading to severe edema. And they also increase the deposition of fat tissue
Behind the eyeball.
right behind the eyeball. This physical buildup of fat and fluid has nowhere to go within the rigid, bony eye socket, so it physically forces the eyeball outward.
And then that is not just a cosmetic issue. The notes say that because the eyeball is pushed forward, immense pressure is applied directly to the optic nerve.
Yes, and that is dangerous.
It can cause blurred vision, severe sensitivity to light, which is photophobia, and a classic sign called eyelid retraction, where you can see a band of the white sclera above the iris. There's also lid lag, where the upper eyelid doesn't move down synchronously when the patient looks down.
The clinical danger here is that the eyes bulge so far forward that the eyelids can no longer close completely over the eyeball,
Even when they sleep.
even when they sleep. The protective tear film evaporates, leaving the cornea exposed to the air. This leads to painful corneal ulcerations, which can cause permanent scarring and blindness.
The nursing care for this is relentless. The treatment involves constantly applying artificial tears, administering steroid eye drops to reduce the inflammation, and literally taping the eyelids shut at night so the patient doesn't go blind while they sleep.
It is incredibly uncomfortable for the patient.
They also elevate the head of the bed to use gravity to help drain that fluid away from the eyes, right?
Yes. And there's another highly specific, though less common, manifestation of Graves called pertibial myxedema.
Pertibial myxedema.
This sounds similar to the swelling in hypothyroidism, but it looks very different. It presents as a dry, thickened, waxy swelling, localized almost entirely on the lower legs, over the shins. It almost resembles the texture of an orange peel or thick keloid scars.
So that is the physical exterior, what is happening internally. Because the systemic symptoms are the exact mirror opposite of everything we discussed with the slowdown.
The internal engine is running at absolute maximum RPM. Let's look at the cardiopulmonary system. We see severe tachycardia, a rapid resting heart rate, often exceeding 100 or even 120 beats per minute.
Wow.
The heart is racing constantly.
The notes mention a widened pulse pressure. If you're listening and don't know what that means, your pulse pressure is the difference between your top blood pressure number, the systolic, and your bottom number, the diastolic.
Right.
Normally, it's about 40 points apart, like around 20 over 80.
Mm-hmm.
Why does hyperthyroidism widen that gap?
It's a really fascinating hemodynamics response. The top number, systolic, represents the force of the heart squeezing. Because the thyroid hormones have amplified the heart's contractility, it is squeezing incredibly hard.
So the top number shoots way up.
Right, maybe to 160. But simultaneously, the body is generating so much excess metabolic heat that the peripheral blood vessels in the arms and legs aggressively dilate. They open up wide to try and release that heat through the skin.
Okay, I see.
This massive vasodilation causes the bottom number, the diastolic resting pressure, to drop. So you might have a blood pressure of 160 over 60. The gap between them is widened.
This causes profound palpitations, bounding pulses, chest pain, and rapid shallow breathing.
Yeah.
They're constantly out of breath because their cellular oxygen demand is just through the roof.
Exactly.
Their internal furnace is blasting. They have a severe, debilitating intolerance to heat. While the hypothyroid patient is wearing a sweater in a 75-degree room, the hyperthyroid patient is sweating profusely in a 60-degree room.
They are miserable.
They run a constant low-grade fever, and their skin is diaphoretic, meaning constantly sweaty, flushed, smooth, and abnormally warm to the touch.
Neurologically, they're entirely wired. The nervous system is hyperexcitable. They are intensely nervous, irritable, and emotionally volatile.
Like they've had 10 cups of coffee.
Worse, the notes mention manic behaviors, severe inability to concentrate, and severe insomnia. They literally cannot turn their brains off to sleep.
That sounds exhausting.
It is. Muscularly, this rapid metabolism burns through ATP energy so fast that it outpaces the muscle's ability to recover, leading to severe proximal muscle weakness and wasting.
And the gastrointestinal system is in absolute overdrive. The motility of the gut is so fast that they experience increased bowel movements to the point of severe chronic diarrhea.
Yes.
And just like we had a biological contradiction with weight in hypothyroidism, we have one here too. These patients experience rapid, significant weight loss despite having a massively increased appetite.
Right.
They're eating 4,000 calories a day, eating everything in sight. But the engine is burning fuel so ferociously that the body is still forced to consume its own muscle and fat stores for energy.
It is deeply exhausting just describing the physiological toll, let alone living it.
No kidding. So how do we diagnose this?
To diagnose this, the physician relies on the history, the physical assessment of the goiter and eyes, and lab results. As you would logically expect, the T3 and T4 levels in the blood will be significantly elevated.
Let's test the corporate analogy again.
All right.
If the factory is flooding the market with excessive product due to those counterfeit TSI antibodies, what is the pituitary middle manager doing?
Well, the middle manager looks at the flooded market, sees an absolute abundance of T3 and T4, and completely halts the production of TSH memos.
Right. It stops asking for more.
So in primary hyperthyroidism, like Graves' disease, the TSH levels will be exceptionally low, often undetectable or approaching zero.
Wow, near zero.
Yeah. The pituitary is trying desperately to shut the factory down, but the factory is ignoring the pituitary and listening exclusively to the counterfeit antibodies.
The notes mention additional diagnostics, like an ultrasound to measure the precise size of the goiter, an EKG to monitor for dangerous arrhythmias like atrial fibrillation caused by the tachycardia, and again, that radioactive iodine scan. Right. But this time, instead of low uptake, the hyperactive gland will rapidly suck up huge amounts of the radioactive iodine, confirming the overactivity.
Before we move to treatments, I want to emphasize a massive flashing red warning written in the provided notes regarding the physical assessment.
This card is crazy.
It states simply, never palpate the goiter.
I saw this and it completely blew my mind. Just touching the patient's neck can cause a medical emergency. How is that mechanically possible?
Consider the anatomy of a highly active goiter. It is massively hypertrophied, engorged with a massive network of blood vessels to support its increased metabolism, and the glandular cells are packed full of preformed, concentrated thyroid hormones just waiting to be released.
Okay.
If a nurse or doctor aggressively palpates, meaning they press, squeeze, or massage the gland to examine its size and texture, that physical pressure can literally squeeze a massive surge of stored hormones directly into the central venous bloodstream all at once.
Like squeezing a soaked sponge directly into the body's circulation.
Exactly. And that sudden, massive bolus of hormones can precipitate a catastrophic, life-threatening event called a thyroid storm.
Wow.
So the clinical rule is absolute. You do not massage, press, or aggressively palpate a known hyperactive goiter. You observe it visually, or you use ultrasound.
Okay, so living with this hypermetabolic state is exhausting, their muscles are wasting, their heart is pounding, and apparently even touching their neck is dangerous. How do doctors actually calm this hyperactive factory down?
The primary goal of treatment is to rapidly block the adverse effects of the hormones and stop their oversecretion. The first line of defense is drug therapy, primarily utilizing a class of medications called thionamides.
The big players in this class are propylthia or sil, which everyone in medicine just calls PTU, and methimazole, commonly known by its brand name Topazole.
Right.
How do these drugs actually work? Do they destroy the factory?
No, they do not destroy the gland tissue. They act more like saboteurs on the assembly line. Specifically, they inhibit an enzyme within the thyroid called thyroid peroxidase.
Thyroid peroxidase. Okay.
This enzyme is responsible for taking the iodine from your diet and binding it to the tyrosine protein. By blocking this enzyme, the drugs prevent the iodine from binding, meaning the factory simply cannot assemble new thyroid hormones.
That's clever.
And PTU has an incredible added bonus. It not only stops new production, but it acts in the peripheral tissues, physically blocking the liver and kidneys from converting the abundant T4 into the more potent T3.
That is brilliant. But there's a huge caveat highlighted in the notes. PTU and methimazole do not destroy the hormones that are already fully formed and stored inside the gland. They only prevent future production.
Exactly.
So it takes significant time to see clinical improvement. You have to wait weeks for the body to naturally use up its existing stockpile of hormones before the hyperthyroid symptoms begin to fade into a remission status.
And choosing between prescribing PTU and Topazole is a critical decision because they have very different safety profiles. They cannot be used interchangeably without thought.
Why?
Methimazole, or Topazole, is significantly more teratogenic, meaning it is strictly contraindicated in the first trimester of pregnancy and during lactation because it can lead to severe fetal birth defects.
Oh, I see.
So if a patient is pregnant, PTU is the mandatory alternative.
But PTU is not a perfect drug either. The notes emphasize it carries a black box warning for a significant risk of severe liver toxicity and acute liver failure.
It does.
The patient's liver enzymes must be monitored constantly. And both of these drugs carry a risk of a terrifying idiosyncratic side effect called granulocytosis.
Agranulocytosis is a severe, rapid, and incredibly dangerous drop in white blood cells, specifically neutrophils.
So their immune system just drops out.
It basically wipes out the patient's immune response, leaving them completely defenseless against bacterial infections. A common cold could become fatal pneumonia in days.
That's terrifying.
Therefore, monitoring complete blood counts is vital. Patients are taught to report any signs of infection, such as a sudden sore throat or an unexplained fever, immediately to their doctor.
The administration rules for these meds are strict too. The patient must take them with meals to avoid severe gastrointestinal upset. They must take them at the exact same time every day to maintain steady therapeutic blood levels. And they absolutely cannot stop taking them abruptly,
Never abruptly.
because the sudden withdrawal can cause a massive rebound effect, thrusting them directly into a thyroid crisis. Plus, many over-the-counter herbal meds and cold preparations interact with them, so the patient has to clear everything with their pharmacist.
Now, alongside the thionomides, doctors will occasionally use iodine preparations to manipulate the gland.
Wait, okay, if you're listening to this, you should be as confused as I was when I read this. I have to push back here.
Let's hear it.
We literally just established at the beginning of the show that the thyroid uses iodine as the raw material to make the thyroid hormone. The hyperactive factory is using it to pump out product. Why on earth would you give a hyperthyroid patient more iodine? Isn't that like throwing gasoline on a blazing fire?
It sounds deeply counterintuitive, I know, but it relies on a fascinating physiological paradox known as the Wolff-Chaikoff effect.
The Wolff-Chaikoff effect. Okay.
When you introduce sudden, pharmacologically massive, overwhelming doses of non-radioactive iodine using medications like SSKI or Lugol's solution, the mechanism actually flips.
It flips.
The thyroid gland gets completely overwhelmed and confused by the massive influx. Instead of using it to make more hormone, the sheer volume of iodine temporarily paralyzes the thyroid peroxidase enzyme. It halts hormone production and physically blocks the release of stored hormones into the bloodstream.
So it basically stuns the factory floor by dumping 1,000,000 tons of raw material onto it.
That is the precise effect. However, and this is a crucial however, it is only a temporary fix.
Oh, really?
The stunning effect only lasts for a short period, typically 10 to 14 days. After that, the gland adapts to the high iodine environment, the enzyme wakes back up, and the gland starts using all that newly provided iodine to manufacture an even more massive surge of hormone.
Okay, so you have to be really strategic with it.
Exactly. So we primarily use these massive iodine doses for two highly specific reasons: as an acute emergency treatment during a thyroid storm, or, crucially, to prepare a patient for surgery.
Right. The notes say giving iodine for 2 weeks before surgery significantly reduces the size and the vascularity of the blood flow of the thyroid gland. It makes the gland firmer, smaller, and vastly less likely to hemorrhage aggressively when the surgeon finally gets into it.
Yes. And there are specific rules for taking this iodine solution at home. Take it 1 hour after your primary antithyroid medication so the enzyme is already partially blocked. Use a straw because the liquid will permanently stain your teeth. And avoid other excessive sources of iodine like iodized salt and heavy seafood.
It also has toxicity signs to watch for: a severe metallic taste in the mouth, stomatitis, which is sore, inflamed gums and teeth, and severe GI distress. And you have to avoid ACE inhibitors and potassium-sparing diuretics due to the risk of hyperkalemia, since the solution actually contains potassium. Oh, and the specific medical antidote for iodine toxicity: sodium thiosulfate.
The final class of supportive pharmacological drugs here are the beta blockers. Drugs like propranolol. It is vital to understand the mechanism here. Beta blockers do absolutely nothing to the thyroid gland itself.
Right. They don't fix the factory.
They do not decrease thyroid hormone production. They don't fix the underlying factory problem at all.
They just shield the rest of the body. They block the sympathetic nervous system's beta receptors. They literally block the fight-or-flight response.
Exactly.
They slow the dangerous heart rate down, lower the bounding blood pressure, and reduce the severe muscle tremors so the patient doesn't suffer a heart attack or a stroke while waiting the weeks it takes for the PTU to finally work.
The nurse's role here is to constantly monitor blood pressure and apical heart rate and instruct the patient to change positions slowly, from lying to sitting to standing.
Because of orthostatic hypotension.
Yes, to avoid orthostatic hypotension, which is getting dangerously dizzy and falling.
But what if medications aren't enough? What if the patient has terrible side effects to PTU? Or what if the underlying cause is thyroid cancer? The notes detail a procedure called radioactive iodine therapy, or RAI.
This represents a permanent, physically destructive intervention. The patient swallows a single pill or liquid containing a dose of radioactive iodine
A
131.
single pill.
Just one. Because the thyroid gland is practically the only organ in the human body that aggressively absorbs and concentrates iodine, the radioactive isotope travels through the blood, goes straight into the thyroid cells, and begins emitting beta radiation
Inside the gland.
inside the gland. This radiation literally destroys the hyperactive hormone-producing cells from the inside out.
It's like a highly specialized smart bomb targeting only the factory.
It is incredibly targeted. It reduces the amount of circulating hormones by physically eliminating the cells capable of making them. It is generally an outpatient procedure, taking weeks to reach maximum effect, but it requires significant, strict safety protocols.
Why is that?
The radiation dose is relatively low, but it is an unsealed source. This means the radioactive isotope is circulating in the patient's body, and their bodily fluids, sweat, saliva, vomit, feces, and urine will actually emit radioactivity for a few days following the dose.
Wow. So the public health protocols here are intense. They have to follow strict radiation precautions to protect their family members.
Very strict.
They're instructed to use a separate bathroom and flush the toilet 2 or 3 times after every use to dilute the radioactive urine. They must wash their clothes and bed linens entirely separately from the rest of the family's laundry. They use disposable utensils and plates.
And distance is key.
Right. They must maintain a physical distance of at least 6 feet from pregnant women, infants, and young children for several days to avoid exposing them to ambient radiation.
And it is obviously strictly contraindicated for a pregnant patient to take this therapy, as the radioactive iodine would cross the placenta and completely destroy the developing fetus's thyroid gland. But the ultimate medical irony of radioactive iodine therapy is that the degree of cellular destruction is very difficult to perfectly calculate.
It's not an exact science.
In aiming to cure the hyperthyroidism, the radiation almost inevitably destroys so much functional tissue that it pushes the patient permanently into lifelong hypothyroidism.
They trade one disease for another, which means they will be relying on taking that daily Synthroid pill for the rest of their natural lives.
Yes. Now, before we move to surgical interventions, we must address the absolute worst-case physiological scenario, the ultimate medical emergency of the hyperactive state. We hinted at it earlier when discussing the danger of squeezing the goiter. The thyroid storm, also known as thyrotoxic crisis.
This is the exact opposite of the myxedema coma. A thyroid storm is a sudden, massive, uncontrolled surge of thyroid hormones violently dumped into the bloodstream all at once.
A violent dump, exactly.
It causes a catastrophic, potentially fatal escalation of the body's metabolism. It's an incredibly high mortality rate, even with the best ICU care in the world.
The triggers for this storm are usually severe physiological stressors, acting upon a patient whose hyperthyroidism is either undiagnosed or poorly controlled by medication.
Like what kind of stressors?
Triggers include massive systemic infection, severe trauma, extreme emotional stress, diabetic ketoacidosis, pregnancy, or, as we emphasize, physical manipulation like vigorously palpating a goiter. Or even proceeding with thyroid surgery on a patient who hasn't been properly prepped with iodine.
The clinical manifestations are the absolute extremes of hyperthyroidism. Extreme hyperthermia, the internal thermostat breaks, and the patient's temperature can rapidly spike over 105 or 106 degrees Fahrenheit, literally cooking the brain.
It is terrifying to witness.
They experience severe systolic hypertension, terrifying delirium, acute agitation, severe vomiting, and abdominal pain. The tachycardia becomes so extreme heart rates of 180 or 200 that the heart can no longer fill with blood between beats.
Right, it's just quivering.
Which rapidly leads to acute congestive heart failure, crushing chest pain, and cardiovascular collapse. The engine isn't just running hot, it is actively melting down.
The management of a thyroid storm requires immediate, aggressive ICU intervention. The primary focus is stabilizing their crashing hemodynamic status. You maintain a patent airway and promote ventilation. They often require mechanical intubation to ensure adequate oxygen reaches the starving tissues.
Oxygen is critical.
You administer massive volumes of intravenous fluids to combat the severe life-threatening dehydration caused by the extreme fever, sweating, and vomiting. You immediately administer high doses of intravenous PTU, or methimazole to block any further hormone synthesis.
And then the iodine, right?
Yes, and follow it rapidly with IV sodium iodide to utilize the Wolff-Chaikoff effect we talked about to stun the gland and stop the release of stored hormones.
And you push IV beta blockers, like esmolol, to immediately slam the brakes on the heart rate before it completely fails. You also give IV glucocorticoids, like hydrocortisone, because, just like in the coma, the adrenal glands are pushed beyond their absolute limits by this massive stress and can fail, leading to shock. But here is a highly specific instruction I noted from your sources earlier regarding temperature management. Manage hyperthermia, no aspirin. I want to dig into this because it's fascinating.
It is a critical detail.
You have a patient burning up with a 105-degree fever. Aspirin is a classic fever reducer. Why is aspirin strictly banned during a thyroid storm?
To understand this, you must look at how thyroid hormones travel through the bloodstream. T3 and T4 do not just float freely in the water of your blood, they are highly hydrophobic.
Meaning they repel water?
Yes. To travel, they must be securely bound to specific transport proteins, primarily one called thyroxine-binding globulin, or TBG. Only the tiny fraction of hormone that is free or unbound from these proteins is biologically active and able to enter the cells to cause metabolic effects.
Okay, so the proteins are like taxis, and the hormone only works when it gets out of the taxi.
Exactly the right visualization. Now enter aspirin. Aspirin, or salicylic acid, has a chemical structure that causes it to aggressively compete for those exact same protein binding sites on the taxis. If you administer aspirin to a patient in a thyroid storm to lower their fever, the aspirin molecules will forcefully knock the stored T3 and T4 off the transport proteins.
Wow.
This suddenly dumps massive amounts of newly free, biologically active thyroid hormone directly into the blood plasma, drastically amplifying the metabolic fire and making the storm significantly worse.
That is insane.
Therefore, you must use alternative antipyretics like acetaminophen, which is Tylenol, or physical cooling blankets to manage the fever.
That is such a brilliant, terrifying biochemical quirk. One drug choice could basically kill the patient. And the physical environment matters immensely too. The notes state you must place the patient in a quiet, cool, incredibly low stimulus environment.
Their central nervous system is incredibly hyperreactive and fragile. A sudden loud noise, a bright overhead light, or simply too much chaotic movement in the trauma bay can trigger a massive spike in heart rate or throw the patient into an intractable seizure.
Just a loud noise can do that.
Yes. Silence, darkness, and calm are literally therapeutic interventions here.
Okay, moving forward. When pharmacology fails, when the patient is allergic to antithyroid meds, when radioactive iodine is contraindicated because they are pregnant or have severe eye disease, or if there is a suspected malignancy or a goiter so large it's crushing the windpipe. The final option is to physically go in with a scalpel and remove the factory entirely, a thyroidectomy.
Operating in the anterior neck is a neurological and vascular minefield.
I can imagine.
The surgeon has two main options. They can perform a subtotal thyroidectomy, where they carefully remove the vast majority of the hyperactive tissue, but intentionally leave a very small remnant of the gland.
Well, I'll leave a little bit.
The hope here is that this tiny remaining piece will produce just enough hormone to maintain normal metabolic function without needing daily pills.
Got it.
The alternative is a total thyroidectomy, removing the entire gland, which definitively cures the hyperthyroidism, but guarantees the patient will require lifelong levothyroxine hormone replacement therapy.
As we discussed earlier, preoperative care includes strictly administering those iodine solutions for weeks to reduce the gland's vascularity so the patient doesn't hemorrhage on the table. But the postoperative nursing care is where the assessments become absolutely critical.
Absolutely.
The primary priority, as always, is protecting the patient's airway, as the surgery was performed inches from the trachea. But the notes state you must meticulously monitor for hemorrhage. And there's a specific physical technique. You check the anterior dressing on the front of the neck, and you must physically slip your hand behind the patient's neck and check their upper back. Why check the back for a front incision?
It comes down to gravity and the anatomy of the fascial planes in the neck. If the surgical site behind the front incision starts slowly bleeding internally, the blood will not necessarily soak through the front bandages.
It goes backwards.
Instead, it will track backward along the tissue planes and pool silently behind the patient's neck and down between their shoulder blades. If a nurse only visually checks the front bandage, they might completely miss a massive life-threatening hemorrhage until the patient exhibits signs of hypovolemic shock.
Or worse.
Or worse, until the internal hematoma swells so large it physically crushes their trachea shut and they suffocate.
Which is exactly why the safety protocols mandate having emergency oxygen wall suction and a fully stocked emergency tracheotomy tray set up directly at the bedside at all times. If that airway collapses, the surgeon has to immediately cut the neck open to insert a breathing tube.
The tray has to be right there.
To minimize swelling and protect the incision, nurses must keep the patient strictly in a semi-Fowler's position. Head elevated at 30 to 45 degrees, support the head and neck with specialized pillows, and instruct the patient to never hyperextend their neck backward, which puts devastating tension on the fresh internal suture lines.
Another major permanent complication to monitor for is laryngeal nerve damage. The recurrent laryngeal nerve, which provides the motor signals to your vocal cords, runs directly behind and sometimes actually weaves through the thyroid tissue.
Oh, wow.
It is incredibly delicate and notoriously easy for a surgeon to accidentally nick, stretch, or sever during the dissection.
So the post-op nurses have to assess the patient's voice quality every 2 hours. They listen for severe hoarseness, stridor, which is a high-pitched whistling sound when breathing, or a weak whispery voice, which strongly indicates the nerve has been damaged.
Correct.
But there is one more massive, potentially fatal complication of this surgery, and it introduces the final characters in our deep dive, the hidden neighbors, the parathyroid glands.
The parathyroids are fascinating. They are 4 tiny oval-shaped glands located directly on the posterior surface, the hidden backside of the thyroid gland itself.
4 of them.
Yes. They are microscopic, roughly the size of a grain of rice, and their tissue looks almost visually identical to normal neck fat or thyroid tissue.
Which means it is terrifyingly easy for even a brilliant surgeon to accidentally scoop them out during a total thyroidectomy, or simply accidentally ligate or tie off the tiny blood vessels feeding them, causing the tissue to die.
It happens more often than you'd think.
And if they're accidentally removed or destroyed, how fast does the body realize its master calcium manager is suddenly gone?
Incredibly fast. Usually within 24 to 48 hours post-op, the patient will crash. To understand why, we must look at the singular job of these tiny glands.
Okay, what do they do?
The sole physiological responsibility of the parathyroid glands is the constant secretion of parathyroid hormone, or PTH. And PTH has one overriding critical goal: to meticulously regulate the precise balance of calcium and phosphorus in the blood.
This brings us to the final major concept, the calcium seesaw. Hypoparathyroidism and hyperparathyroidism. Let's really look at this seesaw relationship. Calcium and phosphorus in the human body have an inverse antagonistic relationship.
Right.
When one level goes up in the blood, the other naturally goes down.
The physiological target is calcium. PTH is the hormone the body deploys to elevate calcium levels in the blood whenever they start to dip. It accomplishes this complex task through 3 distinct mechanisms.
Let's hear them.
First, it targets the skeletal system. It stimulates cells called osteoclasts, which initiates bone resorption. This literally means it tells the bones to break down their hard matrix and release their stored calcium and phosphorus reserves directly into the bloodstream.
Wait, I need to pause on that. It deliberately damages the bones.
It does. Blood calcium levels are so critical to immediate survival, for the heart to beat and nerves to fire, that the body will readily sacrifice the long-term structural integrity of the skeleton to maintain blood levels.
That's intense.
Second, PTH targets the kidneys. It signals them to stop excreting calcium in the urine, holding it in the body. It also commands the kidneys to take inactive vitamin D and convert it into its active form.
And the third mechanism.
Third, through that newly activated vitamin D, it massively enhances the gastrointestinal tract's ability to absorb whatever calcium is present in the food you digest.
I conceptualize the parathyroid glands as the body's calcium central bank.
Okay, let's play with this.
It monitors the economy of the blood. If the blood is suddenly poor in calcium, the central bank prints more PTH memos. These memos go to the massive the skeletal bones and forcefully withdraw calcium to put it into circulation.
That's a great visual.
So what happens when this banking system breaks? Let's start with hypoparathyroidism. The bank shuts down entirely.
Decreased or absent function of the parathyroid means you completely lose the ability to maintain blood calcium levels. You rapidly develop hypocalcemia, dangerously low blood calcium. At the exact same time, because of that inverse seesaw, your phosphorus levels skyrocket and your active vitamin D levels plummet.
As we said, this most commonly occurs as an accidental tragic complication of thyroid surgery, but it can also happen from targeted radiation-induced thyroid ablation or autoimmune disorders attacking the parathyroids.
True.
And the clinical manifestations of suddenly low blood calcium are incredibly distinct, bizarre, and dangerous.
Calcium is an absolute requirement for muscle contraction and nerve conduction. To understand the symptoms, you have to look at the nerve cell membrane. Calcium normally acts as a stabilizer for the sodium channels on your nerves.
The stabilizer.
When calcium levels drop, that stabilization is gone. The sodium channels become leaky, allowing sodium to flood into the nerves prematurely. This makes the nerves incredibly hyperexcitable. The resting threshold drops, meaning the slightest stimulus causes the nerve to fire violently.
The physical manifestations start with strange tingling and numbness, a sensation called paresthesia, particularly around the mouth circummoral tingling or in the tips of the fingers and toes.
If the calcium level drops further, the hyperexcitable nerves start triggering spontaneous motor responses. The patient progresses to severe, painful muscle cramps and then to tetany.
Tetany.
Tetany is a state of constant, rigid, involuntary muscle contraction.
And terrifyingly, this tetany can strike the smooth muscle of the airway. They develop laryngeal spasms, where the vocal cords violently cramp shut, physically blocking the airway and causing severe respiratory distress or asphyxiation.
And if the brain's neurons become hyperexcitable, it can trigger massive grand mal seizures.
The clinical diagnosis is confirmed by drawing blood to check the total calcium, ionized calcium, magnesium, PTH, and albumin levels. But ER nurses and doctors utilize a very specific, fascinating physical assessment trick to test for this dangerous nerve hyperexcitability before the labs even come back. It's called Trousseau's sign.
This is a wild test.
The notes state you wrap a standard blood pressure cuff around the patient's arm, inflate it just above their normal systolic blood pressure, and leave it inflated for a few agonizing minutes. If the patient has latent hypocalcemia, the temporary lack of arterial blood flow, the ischemia, exacerbates the hyperexcitability of the nerves in the arm. It causes the muscles of their hand and wrist to involuntarily spasm, forcing the hand to curl up tightly into a rigid, claw-like posture. You literally watch their hand contort against their will. That is a positive Trousseau's sign.
It is a definitive, undeniable visual indicator of a calcium crash. There's also Chvostek's sign, where simply tapping a finger lightly on the patient's cheek over the facial nerve causes the muscles on that side of the face to rapidly twitch and spasm.
The medical management for an acute hypoparathyroid crisis with tetany focuses entirely on rapidly artificially correcting the hypocalcemia to prevent airway collapse and seizures. It requires the immediate intravenous administration of calcium chloride or calcium gluconate.
But as always with the endocrine system, there are strict rules. You have to push the IV calcium very, very slowly, usually over 10 to 15 minutes.
Why so slow?
If you push it fast, the sudden spike in calcium will cause severe cardiac dysrhythmias and potentially stop the heart. Furthermore, because calcium is highly caustic to veins, you must ensure the IV is patent, as calcium leaking into the surrounding tissue will cause severe necrosis and tissue death.
The patient must be connected to a continuous EKG monitor. For long-term management after surviving the crisis, they will be discharged on lifelong oral calcium supplements, usually massive doses of 0.5 to 2 grams daily taken in divided doses, and potent synthetic vitamin D supplements like calcitriol to force the gut to absorb it.
Now let's flip the physiological seesaw one last time. Hyperparathyroidism. The central bank has gone completely rogue.
This is an increased, uncontrolled secretion of the parathyroid hormone. It is most commonly caused by a parathyroid adenoma, a benign tumor growing on one of the 4 parathyroid glands, forcing it to hypersecrete.
This causes profound hypercalcemia, which is too much calcium flooding the blood, and hypophosphatemia, low blood phosphorus.
This pathology reveals the tragic irony of the parathyroid system. You have an absolute abundance, an oversaturation of calcium in your bloodstream, but your physical bones are literally breaking down and disintegrating.
Yes. The constantly high PTH aggressively decreases osteoblastic activity, shutting down the cells that build new bone, and massively ramps up osteoclastic bone resorption.
So the bones are just melting.
The bones are being relentlessly robbed to supply the blood, drastically reducing bone mineral density. This leads to severe early-onset osteoporosis and agonizing pathological fractures where a patient might break a rib simply by coughing.
Going back to our analogy, it is exactly like hyperinflation. The central bank is irresponsibly dumping all the vault's reserves into circulation, physically ruining the structural integrity of the vault itself.
Hmm.
And all that excess cash, the circulating calcium, becomes a massive liability.
It starts clogging the body's plumbing.
The kidneys are completely overwhelmed trying to filter out this massive calcium load, so the calcium begins to crystallize in the renal tubules. This forms massive urinary calculi, otherwise known as devastating, excruciating kidney stones, which can lead to permanent kidney damage.
The systemic symptoms reflect this systemic toxic overload. Patients may be totally asymptomatic in the early stages, discovered only on routine blood work. But as it progresses, the high calcium suppresses the nervous system, the exact opposite of the hyperexcitability we saw earlier.
So they get weak.
They develop profound muscle weakness, severe loss of appetite, intractable constipation because the smooth muscle of the gut slows down, and crushing generalized fatigue.
And if the calcium level gets too high, the notes specify a critical value of greater than 12 milligrams per deciliter, you start seeing severe psychiatric and mental status changes.
The brain literally slows down, leading to severe depression, confusion, psychosis, and eventually coma or death.
To diagnose this rogue bank, doctors look for those simultaneously high PTH and high calcium lab values paired with low phosphorus. They will also utilize specialized X-rays and DEXO bone density scans to visualize the extent of the damage to the skeleton, looking for thin, radiolucent bones.
The medical management relies heavily on controlling and flushing the calcium levels. Initial non-surgical management includes administering specialized drugs like cinacalcet.
How does that do?
This fascinating drug acts as a calcimetic. It mimics calcium in the blood, binding to the receptors on the parathyroid gland to chemically trick the gland into thinking calcium levels are high, forcing it to stop producing PTH.
That's smart.
They also use bisphosphonates, drugs that bind to the bone matrix to physically block the osteoclast from breaking the bone down further.
Heavy aggressive hydration is absolutely critical here too. We're talking liters of IV normal saline to aggressively flush the kidneys, dilute the blood calcium, and prevent those massive stones from forming.
Right.
They will also prescribe loop diuretics like furosemide or Lasix to force the kidneys to excrete the calcium in the urine. And they aggressively encourage the patient to engage in regular weight-bearing exercise. Why exercise?
Because putting physical mechanical stress on bones activates the osteoblasts, helping drive some of that circulating calcium back into the bone matrix where it belongs.
However, while drugs and hydration manage the symptoms, the ultimate definitive treatment of choice is surgical, a parathyroidectomy.
Yes, the surgeon goes in, identifies the specific enlarged gland harboring the tumor, and removes it. It is usually entirely curative and often done as a minimally invasive procedure today.
Sometimes, if all 4 glands are diseased, they perform a subtotal parathyroidectomy, or even a total removal, with a procedure called autotransplantation.
Autotransplantation is incredible.
The notes say they completely remove the parathyroid glands from the neck, chop up a tiny piece of healthy parathyroid tissue, and physically implant it into the muscle of the patient's forearm.
The arm.
Yes. The tissue revascularizes in the arm muscle and continues to produce PTH for the body. But if it ever grows a tumor again, the surgeon just uses a local anesthetic on the arm to remove it, rather than risking another dangerous neck surgery.
It is an elegant surgical solution to a complex endocrine problem. And bringing everything full circle, the immediate post-operative nursing care for a parathyroidectomy is practically identical to the thyroidectomy.
You must vigilantly monitor the neck incision for hemorrhage, aggressively protect the airway, and paradoxically watch out for a sudden, severe hypocalcemic crisis in the days immediately following the surgery.
Because you just suddenly removed the body's overactive source of PTH. The remaining normal glands have been dormant, suppressed by the high calcium for years. They take time to wake up and start functioning again.
So the blood calcium plummets, and the nurse is right back at the bedside monitoring for numbness, tingling, and inflating the blood pressure cuff to check for Trousseau's sign.
It truly is a massive, incredibly delicate, interlocking feedback loop. A physiological house of cards.
Okay, let's pull back and synthesize this massive journey we've just taken.
We have traveled from the molecular metabolic thermostat of the thyroid gland down to the precise, unyielding calcium banking system of the parathyroid.
We have examined how the absence of a single amino acid or iodine molecule can freeze the entire human engine into a myxedema coma, and how microscopic counterfeit antibodies can redline that exact same engine into a fatal thyroid storm.
We've explored the paradox of how giving massive doses of iodine can temporarily stop a hyperactive gland, how inflating a simple blood pressure cuff can diagnose a catastrophic lack of calcium, and how removing a gland the size of a grain of rice from your neck can cause your bones to shatter or your kidneys to fill with stones.
These microscopic drops of chemicals truly, unequivocally dictate our physical reality.
They govern everything from our baseline core body temperature and our resting heart rate to the structural integrity of our skeleton, all operating through the silent, invisible communication network of the endocrine system.
Which brings me to a final, slightly mind-bending concept for you to mull over as you digest all of this. We talked extensively about how T3 and T4 literally control the electrical speed of our neurological thought processes, and how calcium dictates the electrical firing threshold of our muscles and nerves.
Right.
When you deeply consider the mechanics of that, our very personality, whether we feel sharp, energetic, and optimistic, or whether we feel sluggish, profoundly depressed, irritable, or manically hyperactive, is entirely at the mercy of a few microscopic drops of chemicals circulating quietly in our blood plasma. It profoundly challenges the philosophical idea of who exactly is really in the driver's seat of our minds.
It absolutely blurs the line between psychology and sheer, unadulterated physiology. Are you feeling down, or is your TSH simply slightly elevated?
Exactly. So the next time you wake up and you just feel inexplicably off, maybe you're unusually irritable with your spouse, or you're unusually exhausted after a full night's sleep, or you just can't seem to get warm no matter how many blankets you use. Ask yourself, is it just a bad day? Or is your tiny, unassuming, butterfly-shaped thermostat secretly trying to tell you something? Thank you so much for joining us on this incredibly detailed custom deep dive. Remember, the absolute best way to not be overwhelmed by dense medical information is to just dive right in and look at the why. See you next time.